All right, so I think we'll get started. This is a funded webinar from Alcon Vision, and this just talks a little bit about the accreditation and how you would go about getting credit for attending this webinar. I do want to emphasize that if you want to obtain CME or CE certification afterwards, you'll need to do a brief evaluation and complete that by October 27th to get credit for this. We are meeting the ACCME standards for disclosures of conflict of interest, and each of us will present ours. As well, we will make sure not to discuss unlabeled use, or we'll note if we are discussing unlabeled use. To summarize the objectives for this webinar, I'd like to briefly go down this list. We're going to talk a little bit about pathophysiology, risk factors, and screening for glaucoma, assess clinical trial data on topical agents, appraise clinical trial data on sustained release, and then discuss inequities in diagnosis and management of African American Hispanic populations. This just gives a brief overview. I'm David Friedman. I'm at Mass Eye and Ear, and my co-lecturer Karen Allison is in Rochester, and we're going to have time for questions and answers at the end. I'm going to start now with a case vignette just for you guys to get you thinking a little bit, and we'll ask this again at the end of the discussion. I want to describe a 55-year-old African-American female. She has asthma and moderate primary open-angle glaucoma. You're seeing her for the first time. Her pressure is 23 in both eyes. Her central cornea thickness is 560. And which of these is an appropriate thing to do? And these are your four choices. And please try to vote. It would be great if you would vote, because it'll be more interesting to see how the talks affect your thoughts around this. Just to read the answers out loud, you can assume the eye pressure is higher because the corneas are thin. Avoid SLT because African Americans are at higher risk of failure. Tell her to have her first-degree relative screen for glaucoma, or start her on dorzolamide timolol twice a day and set a target of 17. I thought I was supposed to see some results. Am I going to see some results? Or okay, here we go. So the voting was, about a quarter thought the thickness was an issue. About a third each were going to send for first-degree relatives or try to set a target of 17 and start COSOPT. And so we'll go from there and move on. That's great. Thank you very much. Nobody agreed about avoiding SLT, which I'm thankful for. Okay, so I'm going to start now and talk about risk factors, screening, and just a wide range of topics. I think these are all areas of real interest to me. I do want to note that according to the guidelines I've received, consultant fees from Thea Pharmaceuticals, Health Advances. Also, there should be AbbVie on there. I apologize for it not being written. Three important components of care of the glaucoma patient include case identification, screening, case monitoring, and treatment. And I think that for glaucoma, there have been no dramatic shifts in screening at the moment, but there has been substantial progress towards personalized care, and I'll go over why I say that in the next few slides. I do think there'll be changes in the future, but we're just not there yet. There are lower cost cameras and imaging that could allow for widespread screening. This shows on the left a low-cost camera that takes a very good fundus photo. In the middle, there's a handheld one. Those sometimes have quality issues. And then we could someday be able to get either low-cost OCT or centralized OCT screening that could allow us to identify glaucoma. And you could imagine that if we were to start screening more effectively, we could do it at the Motor Vehicle Bureau. You could have it on the side in a McDonald's or a CVS. Really, screening can happen everywhere. And in much of the world, and a little bit in the US, photo screening for diabetic retinopathy is already in place. And this just shows how important deep learning is to this process. You can achieve almost 100% sensitivity in identifying referable diabetic retinopathy and still maintain a very high specificity. So 93% is quite high. But if you have a population where the actual prevalence is only in the 2% range, having 7% be false positives is not ideal. And so you could even set your bar higher and have an extremely high specificity, which would be the likelihood that a negative individual would test negative and maintain a sensitivity over 90%. So deep learning really in diabetic retinopathy allows you to screen because you're not going to have over-referral. And this has been shown in other populations. In Singapore, this was also shown. And so this became FDA approved. We now have, I believe, 3, there might even be a 4th now, company approved to screen for diabetic retinopathy in the United States using artificial intelligence. What about the optic nerve? You can see here an evaluation of Singapore images with not terrible screening parameters, but if you look at this one area here, you can see that specificity doesn't really get into those 90s that we need. This shows another group from Australia doing a little bit better. And so that someday could be a possibility. But if you look at optic nerve photos on their own, there's just tremendous variability. This is from that Australian data set. And it's hard to tease out exactly who has glaucoma and who doesn't. And it's going to end up leading to probably more referrals than we want if we solely rely on the optic nerve. This gives an example of what is going on in Australia. This is a funded company that's actively screening for eye diseases. It takes an image of the retina, it grades those images, and you can see here that it provides output that tells you that glaucoma is positive or negative. You can see the image. It gives you a file for your folders. So this is already active in parts of the world and being used. This is a very interesting novel approach to screening for glaucoma. This would be using fundus photos to translate to what an OCT might give you. So what you have here on the y-axis is the difference between the predicted and observed retinal nerve fiber layer thickness. And on the x-axis, you have the average of the true OCT findings and the findings of photos. And the photos they're using are photos like these. So this just shows you a photo, and it shows here that the predicted OCT RNFL is 107, or the true OCT is 107, and the predicted is 109. And throughout, you can see that it's actually doing a very good job. The center's around 0. And even with dull images that don't look very visible, it can obtain a RNFL. Now, do I think that this is going to be the way we screen? Probably not, but this could add to how we look at a fundus photo, not just the cup to disc ratio. In addition, these approaches can allow for change over time to be detected. What you're seeing in this middle graphic here is the series of photos on individuals, and this shows the slope of the RNFL using this conversion. So you take a fundus photo, you convert it to a retinal nerve fiber layer thickness, and then as you take photo after photo after photo, you can see if a patient is stable or getting worse. And this has the potential, particularly in studies where people are evaluated on a regular basis, like in diabetic retinopathy screening, to identify patients who are actually getting worse. I think this is one approach, and we'll have more as AI becomes even more widespread in our day-to-day. In terms of angle closure, that's a different thing from these open angle patients. And I would argue that we probably don't want to screen purely for angle closure. And I'll talk about why. I carried out a study with colleagues in China where we lasered one eye and did an iridotomy, the LPI arm. And the other eye was left untreated, which was the control arm. So the individual was his or her own control. And as you can see, rates were very low. EY is eye years, And in the LPI treated eye, there were only 4 endpoints per 1,000 eye years. And in the control eyes, there were 8 endpoints. So that was a statistically significant difference, but very few endpoints. And if we look at what those endpoints were, almost nobody developed high eye pressure. So we looked at all these people who had angle closure at baseline, normal pressures, and almost none of them over 6 years developed a high eye pressure. But some did develop synechia, and it was more common in the control arm. So that's the main difference. There were a few more acute attacks in the iridotomy, in the control arm in this study. And what about those acute attacks? Well, we were dilating patients for this study as part of a research protocol that was IRB approved. And 3 of the attacks occurred after dilation in the control eyes, and 1 in the LPI eye. There were only 2 attacks outside of dilation in any of the eyes, but in particular, if we think of the 900 or so control eyes, which means, less than about 1 in 2,000 patients per year, which is pretty rare. And we could do iridotomies on everybody, but the benefit of doing that has to be weighed against the potential harms. And so we don't really recommend screening for angle closure. I do think that we should be thinking about trying to screen for glaucoma. The U.S. Preventive Health Task Force, which recommends what diseases should be screened for, has recommended that we don't have enough evidence to screen for glaucoma. Angle closure, I think, angle closure itself is not worth screening for. But we want to start getting to where we can screen for glaucoma. If we just screened everyone, that might not be that effective. But we could focus our screening at certain populations, like people with a strong family history, or certain subsets, like African Americans who are older. And the other problem with screening is once you've screened, you're not done. You have to follow up and keep people into care. And nearly half of those who screen positive never show up for the definitive exam. And this was true in Baltimore, where I did a large screening study. And we found that even with free exams, free transport, it was about 50% who showed up. So right now, I'm not pessimistic, but I think we need more work to get to where we can screen effectively. AI should be making inroads into that. And one day, I think in the not too distant future, screening on a more widespread basis will be indicated. But what about monitoring for glaucoma? We now have home devices that allow for testing of glaucoma. We have virtual reality and tablet headsets that would allow testing of side vision. And you could imagine a world in which you go to a centralized location and get your OCT. This just shows a pharmacy with a blood pressure device. And this could either be provided through your insurance, through a small fee. One could imagine ways in which a self-actuated device could be used to administer tests that are too expensive to send home with patients, but are needed to monitor patients. And this shows another example. This could be put in a mall or a shopping or a supermarket and could have, pressures checked as often as you like. You put your nickel in and get your pressure. I think monitoring has really improved over my career, and we're going to continue to have paradigm shifts as to what we do. If you think about how the disease progresses for glaucoma, we really tend to see structural loss before visual field loss. So the structural loss would be kind of steadily going down, and then at some point, the field starts to drop along with that structural change. And OCT can precede visual field loss. I'm giving a case here of a 72-year-old female with primary open-angle glaucoma. Her vision's 20/20 and her pressures are 12 and 10. And if you look at these visual fields, they have a GHT within normal limits. They're reliable. The PSD on the left is borderline significant, but there is no clear abnormality here. You might worry a little bit about the pattern deviation plot there. And what you see is that there is dramatic nerve fiber layer loss identified here. And if you look at this at the bottom, the average nerve fiber layer is normal, but there's a focal loss where the absolute number is 64 in this band, in this classic wedge defect. And yet the field still appears normal. And then over the next 3 years, you can see that this patient developed, as expected, a superior arcuate defect with a strong juxtafoveal defect, which kind of goes along with the picture that we see of lower pressure glaucoma. And the OCT can detect the change as well. And so in this image, the average is 83 and 81, so only a 2-micron loss on average RNFL. But in the inferior quadrant, you can see that it went from 64 down to 50. That's a big drop for that region, and that helps explain why we see so much more field loss over that time period. Another example of a 53-year-old Asian female myopic patient who's fairly myopic, thick central corneas, and has this nerve and this visual field. Now, if you ask me, nothing particularly noteworthy about that optic nerve in that field. And in the left eye as well, it doesn't look that bad. Everything looks pretty reasonable. And when you get the OCT, you're alerted to the fact that maybe the left optic nerve is a little suspicious. The maculas look normal, but if you just look at the areas in this area, this is a little bit lighter blue in the left eye inferiorly. And what you see over time is progression. The 6 o'clock position, same as in the previous case, over 5 years went from 106 to 88. This curve helps you to see that. But the macular OCT did not change over those years. So I just want to point out with those imaging examples that there are times where the OCT is extremely helpful clinically and can even lead, and I have cases where it has led to surgical decisions being made for patients because of the change in the RNFL. And I think you really have to assess these, because if you even look at this one, there's just a big change overall in the thickness over these exam periods from 1 and 2 to 4 and 5. So even though statistically it's not showing up, you can see there's been substantial loss over that time period. I want to really emphasize that the way we test the visual field at present is inadequate. It doesn't serve our patients well enough. Visual fields have a lot of variability. What you're seeing on the x-axis is the standard deviation of the mean deviation. So the mean deviation within a patient can vary by, up to, the average is a decibel. And you can see within confidence, it goes up to 1.5 or 2 decibels in some patients. And that's just because it's hard to take a visual field test. And what this shows is it takes a really long time let's take this triangle, if you have a 1 standard deviation, which is kind of the average variability, it will take, you have 80% power to detect a change of a decibel per year only after you've done about 8 to 10 exams. How much time does it take to do 8 to 10 exams on the average patient? Well, if we look at a study I did a while back at glaucoma practices, the average rate of doing visual fields was less than 1 a year. And many patients being monitored as diagnosed glaucoma with a median follow-up of over a year had no exams, no visual field tests, and only a third had one as often as every 18 months. This really says that we are failing our patients and providing too few tests. What this shows, which I think is a really important concept, and I want you to pay attention here, is that if you want to detect 1 decibel of loss following patients over time, and you did 1 test per year, 1 decibel would take you 5 years to identify with 80% power if you did 1 test per year. And if you did 2 tests per year, it would take you 3.5 years. And even when you get to 3 tests per year, it's 3 years. So think about how often you're testing your patients. This is an intriguing study that Felipe Medeiros recently published. I'm a co-author on the paper. And this shows a patient who's seen 6 months apart. You do your field, you do your second field. And if you ask me, looking at this field, I would say it's pretty stable to me. I don't see much change. The average deviation is slightly, is actually slightly better, and the PSD is no change. So what this study did is it involved 5 individual tests done at baseline and 5 individual tests done at 6 months, all on different days. So now we have 10 tests done within the first 6 months. And if we choose that red circle test and we compare it to this red circle test, that's what you just saw. You just saw this test compared to this test. And there was no change, and you would have just gone on thinking this patient's doing fine. This is how the patient looked at the end of follow-up a few years later. And this shows that there was really a lot of change going on at 6 months if you look at the totality. So this shows much more clearly the first 5 tests and the next 5 tests. And if you draw a line through them, you can see that this patient is declining at almost 2 decibels per year over that 6-month period. The confidence around that is not great. It's significant. It could be anywhere between 1/4 decibel and 3.25 decibels, but it is a significant rate of change. And you and I would want to be treated more aggressively if this change were occurring in our eyes. And what we found in this study of about 200 eyes is that 15% were progressing over 6 months by visual field. And 18 of the 19 eyes that were progressing had rates of change more than 1 decibel per year. And these were confirmed in the later follow-up. So I think we need more frequent testing, and we need to do that outside the office, because who's going to bring people in for 10 tests into their office within 6 months? I don't know about all of you out there, but offices are overwhelmed and patients really can't bear that burden of getting into the office. So ideally, we would monitor more frequently. There'd be less of a burden on patients and facilities. We'd increase access. And the best way to do this would be to monitor at home. And we did a monitoring study where we followed people prospectively. And at 3 months, we looked at their testing using a tablet based on the Melbourne Rapid Fields algorithm. And this just shows that a patient can use a little tape measure, make sure their distance is right, and test themselves. To be honest, this isn't the easiest way to test yourself, and patients did report some difficulty getting set up, but patients did take these tests. An alternative approach would be to use some sort of virtual reality visual field. This was called the EMO, which is a Japanese device. And this also gives a good representation of the visual field. And others, there are many other virtual reality visual field companies now. So I think that we will be able to get all of these tests over time, and that will allow us to see who's getting worse more rapidly. I'm now going to segue over to the treatment options. I think that we have so much more than when I started in my career available for our patients, but it's much harder now to know which treatment is the best treatment. It's really an enormous challenge because a lot of what's out there has not been really rigorously studied in clinical trials. In terms of new medications, the first FDA novel drug approval in almost 20 years, about, I don't know, 7 or 8 years ago, was notarsidil. It has a novel mechanism of action, which inhibits Rho kinase, which increases outflow through the trabecular meshwork. And what you see here is varying doses of notarsidil versus latanoprost, which is in black. And notarsidil was less effective than latanoprost. Greater pressure lowering with latanoprost than with notarsidil in these different doses. And there was substantially more hyperemia with notarsidil than with latanoprost. So ultimately, it looked less effective, and you had more hyperemia. So it didn't seem like a tremendously effective drug. But then there were studies looking at pressure lowering at different levels of eye pressure. And what was kind of remarkable about this drug is that even at lower pressures, pressures less than 22, you get 4 millimeters of lowering, similar to other pressures, which is unusual. Most drugs become less effective as the pressure is lower. So this was an indication that notarsidil might be more effective for these kinds of patients with lower pressure who need even lower pressures. My clinical impression using notarsidil has been that some patients who are getting close to surgery can have good IOP control after starting notarsidil and avoid surgery. In my guesstimate, it feels like 20% have a large drop in eye pressure. Hyperemia can vary a lot, but it can be quite severe, and patients often struggle to stay on notarsidil, but some tolerate it quite well. And one thing that's just not published on and is really just anecdotal opinion is that on some eyes that have been on notarsidil for a while, when I go to do conjunctival surgery, I find the conjunctiva is a little more terrible, and I worry about that a bit. This just shows some of the things that can happen that you don't want. This is cornea verticillata. You can see that in about 15 or more percent. I think a lot of people develop it. You can get subconjunctival hemorrhage. You can get this reticular endothelial edema. This shows, and there's also punctal occlusion that's been reported. And it does seem that the punctal occlusion goes away after stopping the drug. Ropressa can be combined with latanoprost to be, notarsidil/latanoprost or Roclatan. You get more hyperemia than with latanoprost alone, but you do get better pressure lowering with the combination, the fixed dose combination. So this shows that a higher proportion along the x-axis, these are lower pressures, and the black bars are the proportion achieving those pressures, and the fixed dose combination has a higher proportion achieving these lower pressures. The other big drug to come to market that's novel in the last decade is latanoprostene bunod, which is known as Vyzulta on the market. It's made up of this combination that includes a nitric oxide moiety that then increases outflow through the TM, in addition to the latanoprost, which increases uveoscleral outflow. And it was shown to be more effective than latanoprost in seminal trials with a similar side effect profile. And so, you would think that with this finding, you would just use this on everybody, right? You get more pressure lowering, similar side effects, and we think that lower pressures are better. But US healthcare is complicated. Notarsidil can dramatically lower IOP in some people, and I still do try it in some people before moving to surgery, but I worry about how it might impact my surgery. And, I do find that despite the fact that latanoprostene bunod is superior, at least was in a major clinical trial to latanoprost, it's not widely used. It's very hard to get insurance approval in the United States. And I think these barriers play into how we prescribe. There is really this wonderful future that people envision where we might take the patient out of the equation and be able to give sustained release drugs. We know that with topical administration, patients don't always comply. They have to administer themselves and remember. With subconjunctival administration, we don't have to worry about it at all. They will get the medication. And then there's options for, vitreal injections, which could do things helpful to the retina as well. And implants could also lead to sustained release. These are all the kinds of sustained release things that have been out there. There is one FDA approved for Allergan called Durista, which is a single-use pellet that releases bimatoprost. And more recently, Glaukos had their iDose FDA approved, which would allow for a drug delivery system with this sitting in the trabecular meshwork. The bimatoprost ring has not had much progress in a long time since it was first developed. These plugs were tried and did not make it really. So right now, this is what we're looking at, although one could imagine additional approaches over time. We now have newer surgeries. And I think about all these new surgeries, I try to figure out, how do I make a decision to move ahead with doing a new surgery? Many surgical options are there, but none seem, when you see a large number of surgical options to do the same thing, it usually means no one of them is perfect. We really live in a world of ignorance right now. There's just very poor evidence, very limited comparative effectiveness studies. And when somebody says, hey, I'm doing this or I'm doing that, here are some of the questions you might want to say. Do you do it because there's evidence that what you do is correct? Is it just your preference? Or just whatever, I don't have a great answer? So the general principle for surgical decision-making in this instance is to rely on randomized comparative evidence if you can. I generally proceed with the minimum necessary intervention, which I think is different from some people out there. There's a lot of physicians now arguing for multiple procedures at the same time. To me personally, it doesn't make a lot of sense, but that's why we need randomized comparative evidence. And always think about what you're going to be able to do next. Are you destroying tissue that you might need in the future? How are you affecting the overall potential to treat the patient moving ahead? So look at this. There's so many MIGs out there. We have the trabecular bypass procedures like the iStent inject. There's the Hydrus as well in that group. There's a bunch of ablation procedures or trabecular meshwork removal procedures, including iTrack, trabectome, Omni, Cook dual blade. There's suprachoroidal bypasses. The CyPass was FDA approved and removed. And then there's the newer tube-like surgeries that are available, the Zen and PreserFlow, and finally there's novel laser procedures. I'll talk a little bit about each of these. Again, as I've said, and I want to keep emphasizing, there's very few head-to-head randomized studies, and randomized clinical trials demonstrating safety and efficacy are often lacking. So what do? Well, here was the COMPASS trial, which was an FDA approval study, and it showed that if you use the CyPass in addition to phaco, you had greater pressure lowering. So this shows a higher proportion getting greater than 20% pressure lowering. It shows greater pressure lowering by about 2 to 3 millimeters. And then what happened? Well, there was a tremendous loss of endothelial cells. This was the control arm and the CyPass arm, the rate of loss, and it depended on how much of the CyPass was in the anterior chamber. So luckily for me, I had only put one of these into a patient because I waited a while, because I think you don't really know where these harms are, and it often takes time before we truly understand the safety profile of these kinds of procedures. What about the iStent inject? This shows that if you add it to cataract surgery, you have a higher proportion with 20% or more reduction, and you get about an extra 1.6 millimeters. And then there's the hydrus, which is a similar concept, which is you do it at the time of cataract surgery, and then you look at the outcomes. And in this case, these patients all had a washout pressure that was high and were on 1 to 4 medicines at baseline, and they looked at failure as additional glaucoma surgery. And I find that to be a very appealing endpoint. If you can avoid additional glaucoma surgery, which is really, the metal meets the road, this is the definitive thing, that is really great. And so here with the hydrus, you had a 4% rate of additional surgery at about 1,200 days after randomization versus a 0.5% in the group that had the hydrus. And what you see in terms of pressure control, it's a little bit lower in the hydrus group, and the medication use is a little lower in the hydrus group. And then again, if you look further out at 5 years, still almost 3 times as much glaucoma surgery required in the cataract alone group than in the hydrus group. And this shows reassuringly that there's a drop in everybody after cataract surgery in endothelial cell counts, but then there's no further drop in either arm, so that the hydrus does not seem to be adversely affecting the endothelium. And this just looks at medication-free and, almost 2/3 at 5 years versus less than a half if you use the hydrus. There was an interesting study looking at visual field progression as well. And with this analysis, which is a little bit of a complex analysis, but a reasonable one in my opinion, there was better preservation of visual field when you did the hydrus in conjunction with cataract surgery in these patients. There was one study comparing hydrus to 2 iStents. This was the version 1 iStent. And there was a better outcome in the hydrus group than in the iStent group. There are other papers showing that you're very unlikely to have a pressure spike after hydrus implantation as compared to no hydrus implantation. So here's an example of a 74-year-old male followed for pseudoexfoliation. He has good vision, but his pressure shot up to 35 in the right eye. Not that uncommon. And he's starting to show cup-to-disc ratio asymmetry, clearly early preparametric glaucoma. He was tried on latanoprost, could not tolerate it. And this shows his optic nerve. You can see a larger cup-to-disc, but still relatively okay nerve fiber layer. And we elected, because he did have some cataract, to do a phacohydrus. And his pressure afterwards has stayed in the 17 to 20 range on no medicines, and he's doing fine. What about this patient if he was not having cataract surgery? The hydrus is not FDA approved for standalone procedure, and we don't really know if it's particularly effective when it's done as a standalone procedure because there's not much published there. You could do some sort of bypass without a stent. You could do Cook dual blade, bang, which is a bent angle needle goniotomy in places where the cost of a Cook dual blade would be too expensive. There's the Scion. There's many other approaches to goniotomy. There's larger goniotomies like GAT and Omni. And now there's recently approved the iStent Infinite for standalone, which is basically 3 iStent injects. And that did show effectiveness at lowering pressure as a single procedure without cataract surgery. I'm going to briefly segue now to the minimally invasive bleb forming surgery. We know about filtering surgery, that trabeculectomy and tube shunt have complications, hypotony, particularly worrisome, infections, leaks, exposures. And so there are these other tools that might be considered instead of these larger surgeries. And the two major ones are the Zen gel stent and the PreserFlow micro stent. This is a 45 micron internal lumen Zen gel stent. They're coming out with a larger one. And, this can be placed in the subconjunctival space to allow filtration. And this just shows, the quick ab interno approach. A lot of these ab interno surgeries failed. Basically, you just pass the needle across, come out under the conjunctiva, and then inject the Zen. And then as you pull back, you'll start seeing a bleb as the Zen is now being placed in the AC and left there. And basically, it's under the conjunctiva filtering. You can see a bleb forming. So the high failure rate and scarring rates of those led people to do ab externo. And to be honest, the handpiece that was designed for going across the AC isn't ideal. You can see how long and stiff it is, but you can successfully place these into the anterior chamber, just doing it this way and then closing the conjunctiva. And at the end of the case, you can see you have a nice bleb forming just from that simple procedure, and then you just close the conjunctiva. My personal experience with the Zen is some patients have very good pressure control, but I've had frequent scarring. And again, some doctors are still using this quite extensively. I personally use it very little. Once you use that location, you might imagine you're using a very small tube and that it wouldn't affect too much conjunctiva, but I find the conjunctiva in that quadrant is no longer useful for additional surgery. The PreserFlow micro shunt had a comparative study directly against trabeculectomy and was found to be less effective than trabeculectomy. And that's why we currently don't have it as FDA approved in the United States. It's being used in Europe and Canada and other locations. Success in that study was defined as a pressure reduction of 20% or more. Needling was 19% using the PreserFlow compared to 8% for trabeculectomy. And hypotony requiring an intervention was less for PreserFlow than for trab, but vision-threatening complications were similar. And this just shows that trabeculectomy, PreserFlow gets a very quick drop, but then it slowly trends up. Trab ended up with lower pressure at 1 year on fewer medications. And this also shows the failure rates. Again, PreserFlow failed more often. So right now, there may be a slight safety benefit, but it appears not to work as well. There were differences in the use of mitomycin C in that study, and that could have played a role, but that's where we stand right now with the literature. I'm finally going to just talk briefly about glaucoma drainage devices. There are innovations being made. This is the Ahmed ClearPath, which is a valveless tube that now allows you to suture more anteriorly, making it easier to place. And this seems to work similarly to the Baervelt and may have the advantage of being easier to place. There is some concern that that anterior piece might be more likely to erode. There are some early case series, and we'll have to wait and see. There is a novel glaucoma implant that is approved in Asia and in parts of Europe and is being used pretty frequently, at least as I know, in the UK. It's called the Paul, after Paul Chu, who developed it. It's basically the same material as the Baervelt or similar. It's not the same. It's a silicone similar to the Ahmed, but it has a much smaller tube lumen and a large cross-sectional area. And they did find that it worked very well, and you could have good flow on day one. So it's not valved, but you can stent it and avoid hypotony in general. And in that study, nobody needed additional surgery. and they had tremendous pressure lowering. And this just shows the outcomes of that study. And there are more publications confirming that this is a reasonable option. And the hope is that by having a smaller tube, you might have less corneal decompensation. I'm just going to close up here by talking about micropulse CPC. I tried this and did not find it particularly successful in my hands. The hope was that if you just do a pulsed treatment across these superior and inferior regions, you would apply less energy and get the same result. And there have been evolutions on this micropulse in terms of settings, and you can see them just changing. And here in 2020, you have almost 2 seconds, a 360-second total cycle time, and that's the energy level. And it's really as much energy as a standard CPC. So if you do the slow burn CPC, which is 1.25 watts for 4 seconds and 20 spots, that's 100 joules. And the micropulse at 2.5 watts for 180 seconds is 140 joules. And I have not found it to be as reliable as CPC. So that's what I am doing these days, is still CPC. So just to summarize, thinking about glaucoma surgery and what to do, if I need a pressure in the low teens, 12, 13, 14, I target the subconjunctival space. If they're having cataract surgery, I probably would do a hydrus and see if I was lucky and then do a trab later, or if they really need a low pressure, I might just do a phaco trab. If I thought I might not be able to see them post-operatively, or it's a difficult patient to bring back, it might be a tube. If there's no cataract surgery, I'd probably start with a trab. If I'm just looking for high teens, medium reduction, I'll target the native pathway. I think laser trabeculoplasty should be used on almost everyone as initial therapy, unless the pressure is low to start with. I might do a phacohydrus or phaco eye stent, and could consider a goniotomy if there's no cataract. If there's been prior glaucoma surgery, you can needle the trab or put in a tube. You can do external CPC or a second tube, and some endo CPC is indicated in certain situations. My final thoughts are, it's really important to view all new procedures skeptically. Short-term data are not enough, and there's a lot of potential for publication bias. I do a lot more phacohydrus these days and fewer trabs. It's hard to know if one MIGS is better than another. And newer subconjunctival shunting options are associated with a high need for needling, and their efficacy is inferior to traditional filtering surgery, so I still do trabs. Identifying patients is a first step in the process. Screening still has a long way to go, but I think we're getting there. Monitoring is much improved with better imaging and data analysis. And treatment is improved. We have more medications, some longer acting and more surgical approaches, but it's harder to know what is the best approach. Thank you very much. 55-year-old African-American female with asthma, has moderate primary open-angle glaucoma. You're seeing her for the first time. IOP is 23 in both eyes and CCT is 560. Which of these is an appropriate thing to do? No music. Dun, 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 dun.
About 15 more seconds. They're coming up pretty quickly.
No problem. Yeah, no problem. Okay, so, to be a little fair, my talk didn't 100% cover all of these topics, but I will go over this briefly. So the cornea is not particularly thin, so that would not be correct. There's no data that African Americans don't respond to SLT, and in the AEGIS, they did reasonably well. First-degree relatives have about an 8-fold increased risk of glaucoma, and so this is one of the most important things you could do for this patient. I said up there, and it was kind of maybe a little hidden for some, that the patient had asthma. So I would not start on a timolol compound. And, the target might be appropriate, but the compound was a little bit of a trick. So I'll end with that and let Dr. Allison start hers.
Okay, so I'm going to present the case and then I'll go over my talk and then we'll come back later to discuss this case. This is an 80-year-old female with a history of glaucoma for 10 years. The patient is on the latanoprost and Alphagan. Has a history of hypertension for 15 years on amlodipine, hydrochlorothiazide, and metoprolol. She has a history of cholesterol on Lipitor and a family history of glaucoma, past ocular history of glaucoma, cataract with no surgeries, and dry eyes. She's not allergic to any medication, and the family history is positive for her grandmother going blind with possible glaucoma. No history of smoking or alcohol, and no surgical history in the eyes. On examination, the vision is 20/50 in the right eye, 20/30 in the left eye, and the refraction is as shown. Anterior segment, she has a mild APD on the right eye with with a small cataract, 2+ NS cataract, and the pressure of 20. And gonioscopy is open, and the pachymetry is 522 in the right eye and 530 in the left eye. Cup to disc ratio of 0.85 in the right and 0.65 in the left. The visual field shows severe constriction in the right eye, generalized depression in the left eye with inferior arcuate scotoma, and OCT showed significant depression. This is the OCT, showed depression. So the question is, what do we do? Do we add drops? Do we do laser? Do trabeculectomy in the right eye, trabeculectomy or Zen in the left eye, cataract and MIGS OU or cataract and trab OU? So I did not say what race the patient was, or the only thing is that it's a female. Okay. So most people do cataract and MIGS in both eyes. Okay. All right, so let's get started. So my name is Dr. Karen Allison. I'm associate professor at University of Rochester. I'm in charge of the glaucoma department there, and I do a lot of work with health equity research. I have no conflicts. So let's just discuss what exactly is glaucoma. Glaucoma is a group of diseases that leads to optic nerve damage and visual field loss and blindness if not treated. And we know it's a multifactorial optic degenerative neuropathy caused by the destruction of the retinal ganglion cells. We also know that it is one of the leading causes of blindness, and it is the leading cause of irreversible blindness. And currently, there is no cure for glaucoma, primary open-angle glaucoma. So angle closure glaucoma, you could say there's a cure when you do remove the cataract or you do laser. But in general, there's no cure for glaucoma, and early diagnosis is the key to preventing visual loss and blindness. And I'd say early diagnosis and education is the key to preventing visual loss and blindness. So glaucoma is really a public health concern. And the reason I'm saying this is because it is a leading cause of blindness. And the blindness that you receive from glaucoma is irreversible. And in 2020, 76 million people had glaucoma, and over 111 million people is estimated to have glaucoma by 2040. And the global prevalence of glaucoma for patients aged 40 to 80 is 3.54%. And with primary open-angle glaucoma, it's highest in Africa with a prevalence of 4.2, And primary angle closure glaucoma is highest in Asia with a prevalence of 1.9. In the US, the prevalence of primary open angle glaucoma is closer to 3%. So when we look at multiple prevalence studies that have been done in the past, such as the Baltimore eye study, the Beaver Dam study, what we notice is that the majority of the patients in the Melbourne, the Beaver Dam study were actually white, and I'll show you that later on. And the prevalence rate, when you look at the Baltimore eye study, you'll notice that the prevalence rate, which I'm sorry. When you look at this as the Melbourne eye study, and if you look at this graph, this is the Barbados eye study, which has 100% Black patients in that study, and the Proyecto VR study, which has mainly Hispanic. You'll notice that the rate increases as the patient gets older. And when you look at the estimates and you look at all these studies as far as age range, race, gender, you'll notice that in the Barbados eye study, the percentage of patients was 100% Black in that study, with the Beaver Dam study was 100% white. In the Proyecto studies, 100% Hispanic. So from all these studies, they have come up with a consensus that the prevalence of glaucoma is between, for Blacks is between 6 to 7%, for Hispanics about 4%. So this is how they came up with a lot of this data. And if you notice that a lot of these studies were not representative of the full population, but it was representative of the population in which they were conducted. The KEP study was conducted in Tanzania, so because of that, 100% of the participants were Black. And in this, this is the same study that they conducted. It also shows that at every age range that the Black population had a higher prevalence of glaucoma, and the Black men had a higher prevalence over the age of 50, and Hispanic, as they got older, had a higher prevalence of glaucoma. So at every age range, Blacks had a higher prevalence of glaucoma in all races, in all ages and all sexes, while Hispanic has a higher prevalence as they got older, over 70. And that's important to look at. And this is just identifying the same issues with the Barbados eye study and the Baltimore eye study. So what are the risk factors for glaucoma that we know of? There are multiple. One of them is older age. As you get older, the risk of glaucoma increases. African ancestry and Hispanic ancestry, as I've just shown you, has an increased risk of glaucoma. And of course, family history of glaucoma, first-degree relatives especially, increases your risk of glaucoma by about 4 times compared to patients with no family history of glaucoma. And of course, intraocular pressure, which is the only treatable risk factor that we have at this point, the higher the pressure, it increases your risk of glaucoma. And a thinner cornea, and also the thinner the cornea increases your risk of glaucoma. And other issues are type 2 diabetes, and of course, corneal hysteresis, meaning the firmness or the stiffness of the cornea. So the stiffer the cornea, the decreased risk of glaucoma. Myopia has a four times risk of glaucoma. History of eye trauma, steroid use, increased cup to disc ratio, high horizontal cup to disc ratio, high alpha visual field pattern standard deviation increases your risk of glaucoma, heart disease, and so many other things. So what I'm going to talk about now is glaucoma and the socioeconomics of glaucoma. And one of the things that we're trying to do, what a lot of health organizations and physicians are trying to do, is to create some type of health equity in treatment and health equity in education. And what health equity does, it allows us to consider patients and not be determined by race, gender, ability to pay, or economic status, and of course a zip code, but one that allows people to be treated fairly and justly, to give the opportunity to be treated in an equitable way to the full potential of whatever diseases they have, so that they can have increased better outcomes. So when we think about socioeconomics, we can look at a few different areas to evaluate this particular issue. And a lot of this is considered social determinants of health, but I'm going to loop it all into socioeconomics. And one of the things, the first thing that we need to look at is, of course, education. And education failure and health literacy is one of the big issues that is affected by our socioeconomics. The fact that certain schools in certain areas are more funded than other schools, the fact that certain patients in certain zip codes have better availability of resources in their educational system. And of course, health literacy for patients that are older, patients that may speak a different language. That's an important factor in managing the treatment of patients. The other thing is employment. So we know that economic stability is one of the forces that really empower people and allow people to be progressive and to be able to help their families and just create a better outcome for generations to come. So stability in income, employment, and that leads to food security, leads to housing security, and leads to general well-being of a patient. Inferior housing is also a large issue. Environmental housing condition, home ownership, and of course pollution and crime. Because a lot of patients, if they're low socioeconomics, they end up living in rental apartments or housing apartments that are not well funded. And of course, the area may not be the safest here because it's not governed by some of the same rules or powers that govern people in better, or not really better, but more in communities that are more funded. Occupation and environmental hazard is also an issue in a lot of these areas because of pollution, of course, climate change. And we know that pollution increases the risk of inflammation in the entire body, not only in the eye, but in other areas of the body, that leads to diseases like asthma, heart disease, and stress from causing high blood pressure. And there's some evidence to show that it does affect the optic nerve and causes inflammation, even though this is ongoing and increases your risk of glaucoma. And in urban areas versus rural areas, there's more risk of pollution, and a lot of patients of marginalized group end up living in these urban areas. Of course, lifestyle choices, sedentary lifestyle, not exercising, those are some of the issues that can affect your socioeconomic status or your whatever diseases that is being monitored. And of course, behavioral risk. The risk that of crime or not getting into healthy behaviors. Sometimes, depending on where you live, because of need, patients or people may get into situations that they would not normally end up in. And of course, healthcare access and insurance. And we know that that is only 1/5 of what governs a patient's outcome, because if the other 4 is not taken care of, then that's just a big that's just a drop in the whole water, whole sea of problems that occurs in patients that are high risk. And the social context is really the race and racism that occurs with these in these contexts. And these issues are heightened by what we consider discrimination. And there's a few misconceptions that are heightened by this, such as misconception of biological and genital distinct races. And as we know, that race is really a social construct. It's not, there's nothing that says this person is Black, this person is white. It's just something that we have created to identify and separate individuals. And we know that genetically we're similar by over 99% of our genes. So it's just a way to describe patients, which is fine, but the problem is that because of the negativity that's occurred with some of these descriptions, it creates misconceptions to the population at large. A misconception that racial and biological differences create susceptibility to disease manifestation and the difference in the therapeutic responses. And what we have to realize is that a lot of the dynamics that I just mentioned are some of the reasons why some of these patients are more susceptible to disease manifestation and, of course, to the differences in therapeutic responses, and not the fact that they are of a particular race or a particular ethnicity. So issues also heightened by discrimination. The discrimination can be covert or overt. So it can be discrimination in the social structure, as I said, by race and racism. And it can also be health providers can have biases. Some of them are conscious, some of them are unconscious. And of course, individual biases, and of course, institutional biases. And these are some of the issues that we need to address in order to make sure that we have equal health equity in all diseases, not only in glaucoma. So we have inequities in diagnosis also, and this is because of lack of access. The patients, a lot of the institutions are not located in areas that are have availability for marginalized community. They may have to take multiple buses, multiple trains. They have no way of getting to some of these institutions or these offices in order to be evaluated. The lack of representation. There's no one really supporting them as far as the way the system is set up. They may not feel that they have a stakeholder that's have their interests at heart. So a lot of these patients feel that they're not represented, whether it's because the doctors don't look like them or the nurses don't look like them, or when they go to whatever facility, they don't feel welcomed. Lack of insurance coverage. This is a big problem. Even though we have Obamacare, there's still 30% of patients that's not covered by insurance. A lot of immigrants that are here in our country, undocumented immigrants, they have no insurance, but they still have diseases that somehow we have to find out how we can help them instead of them reporting to us when the disease is so advanced that they end up losing vision or in some instances dying. So lack of insurance coverage is a big problem, and I'll address some of the recommendations later. And lack of adequate proven treatments, and Dr. Friedman spoke about that quite eloquently. A lot of these treatments are not proven, and even if they're proven, they're not proven in all populations. Now, I just mentioned to you that we're 99% similar. However, there's so many other structural issues that affect the way we respond to medications or respond to certain treatments that we need to have a diverse group in all these studies. It's not good enough just to have a study or to have a head-to-head study. We also have to have a diverse group of people in these studies. And there's a lot of issues why some of these groups are not involved in these studies. Some of them may have multiple comorbidities, but in order to have proven and adequate proven treatments, we need to find a way to make sure that the population being studied is a diverse population. And lack of education, we discussed that earlier, and that has a lot to do with structural and social problems. But I think each physician or each healthcare provider should have a health equity educational training so that they know how we live in a very diverse world and a diverse country. So we have to have a health equity alert in our inner being so that when patients come in, we can have some empathy and leave whatever biases we have outside so that we can address these patients where they are, so we can have sensitivity and be able to address them where they are, and that so that they can feel comfortable to continue in care and also in being compliant with their treatments. And of course, lack of resources. We discussed that earlier. Fact that a lot of patients do not have insurance coverage, and also the insurances may not be covering the medications that we want to put the patients on, or they may have insurance, but they're underinsured, or they may be working 80 hours a week, but the money that they're getting is not enough to support them in such a way that they can afford the cost of healthcare. And of course, lack of management. A lot of that is sometimes out of our control, but this also comes back to health equity education and health equity implementation in a lot of our services, and creating cultural sensitivity in all aspects of our treatments. So there's lack of access in glaucoma care. Black and Hispanic patients are less likely to see an eye doctor. That studies have shown that. The British Medical Journal show that they're less likely to see an eye doctor. They're less likely to receive preventative care. A lot of times when they go to the doctor is when the disease is already progressed, or when they cannot see. So because there's no preventative care, by the time they show up is when there's loss of vision in one eye and the other eye is blurry, or it's usually at a more severe stage of the disease than normal. And it's usually when they're younger also. So 4 times more likely to go undiagnosed and untreated. And they're more likely to be blind at diagnosis of glaucoma, and they're more likely to need surgical treatment at diagnosis. So as soon as they walk in, the pressure is so high that right then and there, you have to take them to surgery. Patients also feel greater comfort and trust with doctors of similar racial and ethnic backgrounds. They feel more comfortable with doctors that they can identify with, or they have something in common with, whether it's by the sex or whether it's the race or the ethnic background. They just feel more comfortable. I've seen so many patients that they may have had diagnosis of glaucoma for so long, and then they walk in and I'm like, but didn't you discuss this with your doctor? They said, no, I wasn't comfortable. And I'm sure we all see this. So now we know that there's not enough Black doctors and Spanish doctors and Asian doctors to cover all these patients. So what we have to do then is create a more cultural sensitivity to all doctors, so that no matter what race the patient is, what ethnic background the patient is, that once they walk into that office, there's a sense of comfort. There's a sense that they understand the physician and the physician's office understand them and is willing to work with them to create trust. 21% of African American and 19% of Hispanic American patients have doctors of their race or ethnicity. So that means 80% of them are seeing doctors that are not their own ethnicity. And only 4% of all ophthalmologists in the US are African American. So it's so important that we have health equity training and health equity education, bias training, so that when patients come into our offices, when they leave, they feel like they have been heard, and also that they are willing to comply with their treatment. And so that 5 years down the road, they don't show up and they're blind and say, well, a doctor told me I had glaucoma, but I didn't trust that doctor. So lack of insurance coverage. One other thing. So we may not have 80% of patients are going to see doctors of different races and ethnicity. But one of the things that we could do, because we don't have enough doctors, is one, we could train other doctors of races so that we have a more diverse group of providers. But the other thing that we can also do is bring in nurses and technicians and health counselors, and just to help with some of these lack-offs until we get to the point where we have a greater amount of diversity in our physician network. But in the meantime, we can also employ more diverse group of technicians and nurses, and so that when the patients come in, they can feel comfortable. Also, without insurance, patients are less likely to afford a visit. And they're only going to come when there's a major problem. They're less likely to afford medication, and they're less likely to receive preventative care, which we also went over. Because if they have limited resources and they're feeling fine, there's no reason for them to pay that money to get preventative care. They'd rather pay it to eat or to pay their rent or whatever other choices that they have to do when they have limited resources. So this graph was presented by the U.S. Health Insurance Coverage, and it shows that.
I think we're going to have to wrap up in the next 5 minutes or so, if you can.
Okay, no problem. Thanks. So it showed that the 26% of patients without that were underinsured, and 41% of patients that had no insurance were less likely to see a specialist, less likely to visit a doctor. And so in the ocular hypertensive treatment study, it showed that 60% of drop in probability of developing glaucoma, 4.4% of patients with that were treated had a less chance of developing glaucoma, while 9.5% of patients that weren't treated had a greater risk of developing glaucoma. And the aim of treatment was by 20%, and only 40% of Blacks were enrolled in the study. And in another, so that just shows that if they're caught early and we treat early, there's less chances of these patients going on to getting glaucoma. In another study where we looked at 105 clinical trials with over 33,000 patients, 70% of the participants were white, 16% were Black, and 3% were Hispanic, which shows an underrepresentation of Black individuals and Hispanic individuals in most of these clinical trials with the drugs that they're taking. So at this point, we don't really know how effective these medications are. We think they are, but we're not 100% sure because they were not adequately represented in these studies. And the same thing for the surgeries. 67 clinical trials with over 6,000 patients, 70% were white, 16% were Black, 5% were Hispanic, and Black participation in mixed trials was about 13%. So the underrepresentation of these trials in these patients that are at risk for glaucoma was insufficient. So lack of representation in both medication and clinical trials, and lack of representation in availability of competent care and equitable in treatments. So let me just say real quick, some of the problems of lack of patient education, lack of trust, ineffective treatment, treatment non-compliance due to schedule conflicts and cost of medication treatment, of course, bias in treatment and bedside manner. So, so how to avoid these? Some of these patients have the fear of the medical system, the stress in the medical community, a lack of common cultural background and language barriers, lack of a relationship with eye care providers, and healthcare education about the diseases. So, some of the ways that we can treat some of these issues is partnering with community influencers such as church leaders, community leaders, and primary care and family physicians, and run screening featuring participants over 80 with over 40 with a family history of glaucoma, Hispanic and African ancestry, and 2 years of not receiving eye care. So those are some of the things that we can do. Adequate follow-up, increased community-based care and screening, and access to physician of similar ethnicity. And increase affordability of Medicare, accessible care for screening, and coverage assistance through pharmaceuticals and support. All right, thank you so much. I hope that was helpful, and thank you for your time.
Let's go to the post-test.
Okay, all right, let's go back to the test.
No, I think it's at the end.
Yeah,
You just keep
yeah.
going.
Sorry.
Yeah, there you go.
Share screen. Let me just go back to presenter. Those tests. I'm sorry, let's just go to the post tests. Okay. So the patient is 80-year-old on latanoprost alpha-GAN, had glaucoma for 10 years, multiple medical problems, no drug allergies. It's a typical glaucoma patient that we see. Glaucoma possibly in the grandmother, no smoking, no surgeries. Vision is 20/50, 20/30, hyperopic. Anterior segment is 2+ NS cataract. Gonioscopy is open. Pachymetry is 522, 530, which is low, and cup to disc asymmetry. Visual field loss. What would you do?
Just a few more seconds. I'll show the results.
A cataract and MIGS. Okay, same thing. All right.
So what are your
So
thoughts about these? Yeah, do you want to go over them?
yeah, so this is a patient that has had glaucoma for years, showing glaucoma progression in the right eye more so than the left. They do have a cataract, but we could do cataract and MIGS. That's a good choice. The right eye before the left eye. We really want to get a very low pressure, so we'll try to figure out what MIGS we could do. We could do cataract and Zen in the right eye, and then SLT in the left eye, or because she has cataract in both eyes, we could do cataract and MIGS in the left eye, and possible cataract and Zen, which is another type of MIGS in the right eye. So I think the answer could be E, which is cataract and MIGS, or cataract and MIGS in the right eye and possible laser in the left eye. So there's really no one answer that's correct. Does anyone have any thoughts, Dr. Friedman?
No, I think that probably I would do cataract and some sort of MIGS as well, and then go from there, hoping to achieve the targets.
Right.
Well, thank you very much. We have 4 questions that were submitted by audience members. The first one asks about the role of autoimmune pathophysiology in glaucoma. and new information in this area. Sorry, my suit's all off. Do you want to comment on that at all?
So with glaucoma, there is so many new findings that are coming out, and we know that with exposure to certain pollutions, it increases the risk of any type of autoimmune disease. So I think, in essence, there is an increased risk of glaucoma, but I don't think it's that clear cut. I think patients with uveitis that are from autoimmune diseases can go on to get uveitic glaucoma, but as far as primary open-angle glaucoma as a cause from autoimmune disease, I don't think that's clear at this point. There's just there's a possible but it's not as clear cut as that. But for uveitic glaucoma, yes.
So one intriguing publication in Nature about 4 or 5 years ago had germ-free mice that didn't develop glaucoma despite insults. And so we certainly know that our immune systems are playing a role, and there are people studying autoimmune conditions and glaucoma. It's hard because there's lots of different forms of autoimmunity, and really defining whether or not there's an increased risk. There's some signal that there is, and we certainly see patients that don't have uveitis who get glaucoma with autoimmunity, and it's just a very tough topic to study well. So I did not see any change with COVID in terms of optic nerve pathology. There are some case reports of COVID in the conjunctiva. I don't know about much related to the optic nerve, so I'm not going to go too far into that. My feeling about pigmentary glaucoma is it's a more worrisome form of glaucoma than all secondary glaucomas are more dangerous. So if you have pseudoexfoliation, if you have pigment dispersion, the problem is the pressure fluctuations and the potential for very high eye pressures can cause severe damage. And so I just watch those people more carefully. I mean, some people with pigment dispersion never develop glaucoma, but if a person's having pressure control issues, they can very rapidly have severe nerve damage if it's out of control and not detected. I don't know about you, Karen. What are your thoughts?
Yeah, so pigmentary glaucoma is really interesting because you have patients that have had pigmentary dispersion syndrome for years and have not developed glaucoma, and then you have some that develop very advanced glaucoma. So I think part of it may be lifestyle attributable to that, because I think a lot of patients that are exercise increases the amount of pigments that are dispersed. But I also think that in some way, depending on the type of exercise the patient does, may have some beneficial factor. I also think that and there's no correlation with the amount of pigments also, because you have some patients that have severe pigmentation in the trabecular meshwork, and their pressures are still within normal. So I think a lot maybe just lifestyle, and also depends on, as they get older, maybe the lens gets larger. It's hard to say.
And now we're just maybe a little bit over, but let's have you please, Karen, answer the last question, which is regarding insurance coverage inequities in glaucoma. Well, it's more of a comment, but the Medicare copay, medication copays, what are your thoughts about that?
Yeah, so I think that's a big issue, because with Medicare, a lot of times they do not cover certain medications. They have the Medicare HMOs, which unfortunately a lot of the marginalized group end up having, which has sometimes lesser coverage than the Medicare and secondary insurances, because so there's that gap in coverage with a lot of these patients. And with Medicaid, they cover certain groups of medication, not necessarily the ones with the least amount of side effects. So a lot of times these patients end up getting a lot of compliance issues because of side effects. So it's a huge topic that I could talk to you for hours about the insurance coverage, but unfortunately we don't have the time. But I think it's a big issue, and I think one of the things that we need to push for is to have some form of screening, just like what David said about going into the pharmacy and getting your blood pressure, having screening centers where patients can go and at least get screened without having to pay, or maybe pay a minimum amount, something like what they have in India.
And I guess there was one last question from Kathleen, just in terms of the ZAP trial and it showing that there wasn't much benefit of iridotomy. I basically, overall, for a normal patient with narrow angles, will discuss with them the potential for an acute attack, which is rare but can be serious. And then I will discuss with them the potential for dysphotopsias. There can be some glare through the iridotomy. Maybe 1 in 30, 1 in 50 people have some mild complaints and very rarely severe complaints. And then I let them make the decision. Now, for a patient who needs frequent dilation, a patient who goes to remote areas for extended periods of time, those people I might encourage to have the iridotomy a little more than if otherwise. But I'm very comfortable watching people with narrow angles and normal exams. But I know other people get very nervous in those situations. So that's my approach.
I just want to say one quick thing about the federal qualified healthcare system. Yeah, that's a great program. However, it's not available to everyone.
Yeah, I've had the same concern. FQHCs in some locations provide eye care services, and others they don't. And it's not always that easy to get follow-ups in that setting. But I agree, it's an area where we could serve a lot of people if we could integrate the eye care into that. And I think that's a good suggestion.
Yes.
So just to close out and summarize, we're in an evolving time in eye care. There's a lot changing. It's very important to think thoughtfully about how you practice and whether your practice is guided by evidence or by your own gut. Patients have a lot of varying needs and backgrounds, and getting to know and understand your patient and the barriers to their obtaining the care that they need, the problems with the overall society in which we live, which often treats some groups differently from others, can play a big role in the care we give to people. And I think Dr. Allison was trying to emphasize that, and I couldn't agree more. I think we've gone over a lot today. I hope people are able to take some of this back to the office. Thank you very much, Dr. Allison, for your talk.
Thank you. Thank you so much.
Thank you, everybody, for joining on a Saturday morning. Appreciate it. Have a good one. Bye-bye.